Hello, good evening, everybody. You are most welcome to one of our ENT grand rounds at Guy's and St. Thomas's Hospital here. We are really fortunate to have this fantastic professor of otolaryngology. So Jonathan Aviv, he works at the head and neck surgery at School of Medicine at Mount Sinai Hospital in New York. He is also the clinical director of the Voice and Swallowing Center at the ENT and Allergy Associates in New York. He's done a lot of work in laryngology and dysphagia. Among some of the things that he's done, he is an inventor, an author, and also an educator, a physician, and a surgeon. He's best known for his invention of flexible endoscopic evaluation of swallowing with sensory testing. This is a medical device that allows us to do office-based assessment of oropharyngeal dysphagia for various swallowing disorders without the need to use any X-ray or video fluoroscopy. He is also known for his development of the transnasal oesophagoscopy, a method of examining the esophagus without using conscious or intravenous sedation in the office. From 1991 to 2009, he was a full-time academic surgeon and director of the Division of Head and Neck Surgery at Columbia University College of Physicians and Surgeons. Ladies and gentlemen, I will now hand you over to Professor Aviv to give his talk on COVID-19 long haulers with persistent shortness of breath in normal pulmonary imaging.
The presentation today is going to be on COVID-19 long haulers who have persistent shortness of breath, but normal imaging. We will ultimately be talking a little bit about how we use diet to control this. And if you want more information, acidwatcher.com is a website where multiple recipes are present and replenished. An even more up-to-date way to follow what we're doing is on my Instagram at Dr. Aviv. And if you're really feeling saucy, on Facebook, there are two groups, one of which is called the Acid Watcher Diet Support Group. Within the two groups, there's some 45,000 people who follow some of our dietary recommendations. And it's very creative from all over the world. There are thousands and thousands of recipes. How food plays into this, I'll show you hopefully shortly. So in the United States, we call it long haulers. In the UK, they call it COVID long. And of course, there has to be a more complex name for all this. And that's what our CDC is now calling post-acute sequelae of SARS-CoV-2 infection, or PASC. I still think we're going to call it COVID long or long haulers for a long time. So what is the definition of a long hauler? It's a diagnosis of COVID-19 based on both symptoms and or diagnostic testing for SARS-CoV-2. Now, early on, and I'm sure we all can relate to this experience, say beginning March of 2020, it was very difficult to get a COVID test. So we had to initially rely on what we thought were typical symptoms at the time. And then from there, we tried to treat as best we could. For the long haulers, it's something that symptoms that persist for a while. So the definition, and of course this may change, but right now we're calling it not having returned to pre-COVID-19 levels of health and function after 6 months. The symptoms suggest long COVID, but there's no evidence of permanent damage to the lungs, to the heart, the kidneys that can cause these symptoms. So what are these symptoms? There are a variety of symptoms, and one's clinical experience will guide us one way or the other. Fatigue, body aches. Today, we're going to focus on the shortness of breath, the brain fog that people talk about, inability to exercise, headaches, sleep disturbance. These are among the symptoms. Again, today, we're going to be talking about shortness of breath. And the reason we're focusing on the shortness of breath is that with normal cardiac workup, normal pulmonary workup, these patients have persistent symptoms, and soon you'll see exactly what they complain of. And because the imaging is normal, these patients are often told, hey, you're okay, get out of here, when they're really not okay. And we can, especially as ENTs, we can help them. So what's the incidence? And I try to make this as current as possible. So as of last week, 33 million Americans were confirmed to have COVID, about 5 million in the UK, 56 million in Europe, and 184 million cases around the world. However, these are people who just were diagnosed. In other words, there was some testing and there was positive testing, but we estimate that these numbers could be 3 times that. So if you're looking at the low end, that would be 10% of those infected will develop some type of long hauler symptom. So again, on the low end, 3 million Americans, 500,000 in the UK, 5.5 million in Europe. But at the higher end, so if you believe what the estimates are, we're talking about 10 million people in the United States, 1.5 million people UK, 17 million in Europe. So it becomes quite a problem. And just today, again, in our major newspapers, there was talk about long haulers. A study just came out from Switzerland saying it was 26% of their population. So this is going to morph. So this is not going away anytime soon. We were talking a little bit about vaccine hesitancy with Professor Karagama before the presentation started. And we're hoping that the people who can get the vaccine. Anthony Fauci in the United States has an opinion about what causes the COVID long hauler symptom. He felt it was similar to myalgic encephalomyelitis or chronic fatigue syndrome, which all of us have dealt with. There's some ENT manifestations of this. However, as we all know, generally chronic fatigue syndrome is very difficult to treat. So little hope is given to these patients. So, you can imagine the frustration building already and the people we take care of. So there's some theories as to the cause. One is ongoing low level of inflammation in the brain. Some people believe it's an autoimmune condition in which the body makes antibodies that attack in the brain, or perhaps decreased blood flow to the brain due to what is called increasingly dysautonomia, or problems with the autonomic nervous system, which can result in a post-viral, meaning after infection with COVID, vagal neuropathy, which is what's going to be our focus here. Those of us in ENT have long dealt with vagal injury and its consequences as laryngologists, people who study the voice and swallowing. We see a tremendous amount of that over the years, but now in the time of coronavirus and COVID-19, it's particularly center stage. And I believe we have a window to help many, many people. In approximately October, working with my co-authors, Sujana Chandrasekhar here at ENT and Allergy Associates, and Byron Thomashaw, who is a well-known pulmonologist at Columbia University, we published a paper on the subject today on post-viral vagal neuropathy from COVID-19, which is presenting as persistent shortness of breath with normal imaging on either chest CT or chest X-ray. We have a shortened version of this that you could have access to. It's COVID era SOB, SOB standing for shortness of breath. So what are the characteristics? And this is really important because patients are coming in, and very often patients will come in without having seen a lung doctor, without having seen a cardiologist, and you really don't know where the patient stands, where you stand. So certain symptoms are critical to find out about, and it's very important to ask some basic questions. And one of the questions I ask patients when they come in, they say they're short of breath. And some people have a lot of trouble describing the shortness of breath. They don't say, I'm short of breath. They say, I can't catch my breath, or I feel something weird with breathing. And they go like this, I can't feel right. And when people say shortness of breath, I'm like, but sometimes you don't get that history. So I ask the patient, do these symptoms, whatever they are, ever wake you up in the middle of the night? Not saying, does it happen at night? That's different. Does it wake you up in the middle of the night? If it's waking patients up in the middle of the night, you got to think cardiac, you got to think pulmonary. But if it's not, and it's primarily when they're not asleep, that sort of brings us to where we think this is coming from. And those of us treating vagal neuropathy know, in a sense, in the vernacular, when you go to sleep, the vagus nerve goes to sleep. So people with paradoxical motion of the vocal folds, who have cough, some shortness of breath, generally when they go to sleep, that's it. But when they're up, that's when the problems happen. The next part of the questioning has to do with exercise. When I ask people, does this feeling you have limit your exercise tolerance? Now, it's a tricky question. Some people say, I can't exercise. Or every time I try and exercise, something happens. Well, what we really want to know is, after you exercise, after activity, after you climb up the stairs, after you walk across the street, does that bring on the series of symptoms? And again, relating to the vagus, exercise typically overcomes the resting tone of the vagus. The original description of paradoxical vocal fold movement disorder in 1983 at the National Jewish Hospital in Denver was a teenage woman who was scoring 3 goals a game on the soccer or football field. As soon as she got to the sideline, she couldn't breathe. But during the game, no problem. So that's what we want to know. You want to ask the patients, do you ever feel this feeling after any type of activity? Again, if you're limited, you have to rule out cardiac, right? So as more and more COVID long centers, or what they call post-COVID clinics, have sprung up all over the United States, and especially in the academic centers, often the cardiologist weighs in and rules out, the pulmonologist weighs in and rules out. So we get these patients afterwards, so a lot of the work is done, but sometimes you don't have the benefit of that workup. So these questions, does it wake you up in the middle of the night? Does it limit your exercise tolerance? Or are you feeling it after you exercise, is critically important. So again, thinking along the lines of a vagal injury, typically talking, shouting, screaming, singing, karaoke will trigger this shortness of breath. And often in the clinic or the office, when the patient's talking to you, suddenly they'll stop and they'll catch their breath, because the activity of the vagus causes the closure. And I'm going to show you a video shortly of this in action. Classically, perfumes, odors, smells, changes in temperature going from hot inside to cold outside, or vice versa, can bring it on. And then finally, and this is how it backs into some of the food-based solutions we're developing, very acidic foods. That's the handful of foods less than pH 4 can trigger symptoms. So what is less than pH 4? It's only 6 things. I call them the dirty half dozen. Any flavored beverage in a can, bottle, or box. So soda, bottled iced tea, and then what I call the 4 under 4. 4 healthy foods under pH 4. Citrus, tomato sauce, not tomato, vinegar, and wine. So people are saying, oh, I just bought a vineyard in Sonoma. What am I going to do? Well, we'll talk about that. So here's a video of a patient who, classic symptoms, had COVID 6, 8, 9 months ago, persistent shortness of breath. and doesn't have symptoms in the middle of the night, meaning it's not waking the patient up. It doesn't limit exercise tolerance. And what you're going to see, and I'll show it to you a couple of times, and just to review the anatomy for those of you not familiar, this is the right vocal cord. It's the V. This is the left vocal cord. The dark triangle is the windpipe or the trachea. This is someone who has some acid reflux. You can see the arytenoids are swollen. Epiglottis over here. So down here is anterior, 12 o'clock is posterior. This is the posterior pharyngeal wall. So I'm going to run this. Hopefully you can see what's going on. And just as a primer, so during quiet breathing, the vocal cord should be open. When one phonates or talks, the vocal cords close. In between, the vocal cord should be open. In between here, talking and breathing, the cord shut and sometimes stay shut, especially after phonation. The simple passage we're going to have the patient say is, "We see 3 green trees." So here we go. So I'm going to stop it. I'm talking and the patient's airway shuts, right? Shouldn't be, right? When I'm talking, the patient's airway should be open. So I'll just run this through. Okay, so what happened there? I'm talking, the patient shuts their airway. That's paradoxical motion. Then the patient says, "We see 3 green trees." Instead of opening the airway, shuts the airway, and you saw it stayed closed for 6, 7 seconds. It opened for a second, then shut again for several seconds. You have to think about what's going on. Over a 20 to 30 second period, the patient's airway is shut for 75% of it. You're going to feel shortness of breath. So I'll run it by again. Airway shuts, opens for a second and shuts again. That's paradoxical motion. This is not laryngospasm, right, which is sustained closure of the vocal folds. This is paradoxical motion. So how else can you pick this up? A lot of primary care doctors who encounter these patients say, "Well, can't we just send everyone for respiratory retraining and diet modification when we get these symptoms?" Well, no. What if this shortness of breath is not because of paradoxical motion, but because of something going on in the heart or lungs? So it's essential that ENT get involved to take a look at the larynx. This is not something that can be done on a virtual exam. Maybe one day patients will scope themselves. They'll, whip out their scope and pass it, and we'll be able to see it. But until that happens, they got to come in and we got to take a look. However, you can do spirometry, right? Part of pulmonary function testing. And for those of you who've seen a lot of these, in a typical normal spirometry, the inspiratory curve is here, the expiratory curve is here, and the inspiratory curve is down here. So when you have closure of the vocal cords, you'll have a flattening of the inspiratory curve, right? The cords are closing, so you can't have this sort of oval shape. It gets cut off. And as we've seen, not only again in the time of COVID, but when we saw years ago or ongoing until COVID, patients with vagal neuropathy, if they did get spirometry, often they went to the lung doctor. We actually saw this pattern, and the patients were given Symbicort. They were given something to dilate the bronchi when the problem is the inspiratory curve, not expiration, right? Inspiratory. So you can see this. So I always ask patients to bring in their spirometry, because very often the diagnosis has been made, although one may not realize that the diagnosis has been made. So how do we treat this? The way we treat it is generally without medication, and we're not injecting anything. So for vagal neuropathy, you've all read about using neurotropic agents like gabapentin, Lyrica, amitriptyline, nortriptyline. Some people advocate injecting xylocaine to the superior laryngeal nerves in the neck, one of my faves. But I don't like any of those things, and we can talk about it. But have you ever seen patients with severe pain after talking, vagal neuropathy, and they're on 2,400 to 2,700 milligrams of gabapentin? They're often so sedated they can't enjoy their life. So there's not only gotta be another way, there is another way, and it's called respiratory retraining, which is increased resistance breathing exercises administered by a highly trained speech language pathologist. They don't teach respiratory retraining in speech therapy school in the United States. Maybe they do in the UK, maybe in Europe. And maybe now they're going to start because of COVID long. But for now, we have gotten together a group of absolutely stellar speech language pathologists who know how to do this. And using increased resistance breathing exercises, they are able to train the patients to open their airway instead of closing it. I know it sounds fantastic and ridiculous, but we studied this a decade ago for years, and it does work. So this is what we do. We send the patients. Part one is respiratory retraining, and our speech therapists are available virtually, and they see patients from all over, no matter where the speech therapist is. The other part of this, as you saw on the previous slide, is we want to take away things that aggravate the vagus. Very acidic foods will affect the end organ. So we're trying to avoid these very acidic foods where we talked about the soda, bottled iced teas, citrus being lemon, lime, orange, grapefruit, pineapple, tomato sauce, vinegar, and wine. And we also suggest anti-inflammatory smoothies and juices, and I'll show you what that is in a moment. So we start off with something called a watermelon cucumber blendy. I use the word blendy as a riff of blend as opposed to juicing, because a lot of the juicing machines take out the fiber. We want to keep fiber. Fiber is very anti-inflammatory. The basic recipe is right here. It's 1.5 cups of watermelon, a cup of cucumber, some ice, and optional, you could put some flax meal. Now, why are we even doing this? So there's some science behind it. Watermelon contains lycopenes, even more than tomato, 6 to 5 more tomato. It's very, very powerful natural anti-inflammatory agent. And we combine it with cucumber, which is very high in lignin, which is another powerful anti-inflammatory agent. Flax meal, not only high in lignin, it also has a lot of a micronutrient called herbacetin. For the biochemists there, herbacetin binds to the CL3 protease in the cell, which helps prevent cell damage from COVID-19. Now, this is not how we're going to treat COVID-19, but it's good to have food-based solutions that will cool this whole thing off. And then we can talk about adding 2 fingers of vodka at some point, and we'll call it the Bargava Martini, but maybe that's for a live presentation. So what can you do as clinicians? When you see these patients, you want to first rule out a cardiac or pulmonary source, right? Or it could even be neurologic injury. So a workup needs to be done. As I mentioned, a lot of people just come in sort of off the street because they read one of your articles, they saw a presentation, and the basic workup to rule out very serious things, heart, lungs, brain, are not done. It's got to be done. Even when you see this, there could be something concomitantly going on that you're missing. So I always send patients to our pulmonary neurology colleagues and cardiologist colleagues to get that ruled out. You want to ask those questions Does it wake you up in the middle of the night? What's your exercise tolerance? You can always refer for spirometry. There's been some reticence to perform spirometry in the time of COVID, but if one's been vaccinated, COVID testing, it's being done with greater and greater frequency. And then refer to your ENT colleagues. I'm going to show you the video again, and I'll narrate through it in case that's helpful. So during quiet breathing, so I'm talking, telling the patient to say this passage, and you see the airway shut, right? Remember, the airway should be open. I'm looking at you, you're looking at me, airway open, not airway closed. So here the airway's closed. That's the first hint. We see 3 green trees and boom, 1 1,000, 2 1,000, 3 1,000, 4 1,000, 5, 6 1,000, 7 1,000, 8 1,000. So almost 9 seconds, no airflow. That's not normal. That's paradoxical motion, and it explains what's going on. I'm happy to entertain questions from the team.
Excellent. What a fantastic presentation, Jonathan. Wow. I never knew there was an anti-inflammatory smoothers juice. I've just thrown away my watermelon in the bin now. I'm going to retrieve it and wash it, mash it, and drink it for the night.
Yeah, listen, Kubu, I start every day with one of these smoothies. I do, since before the pandemic began. Well, right around the time, right? So mid-March last year, before my morning walk to work. So it tastes good. It's anti-inflammatory. We won't even bring in the benefits for those with reflux disease. I, in fact, call the watermelon cucumber smoothie food steroids. I use it when I have a sore throat, and a lot of our patients are extremely creative and they add things to it. When you're adding citrus to it, you can neutralize the acidity of a pineapple, of an orange, of berries, cherries, with a cup of non-dairy milk. I use the acronym OSCAR, which stands for oat, soy, coconut, almond, rice. So any non-dairy milk will neutralize the acidity of acidic fruits. In a blender, you have to blend it. You can't have a bite and a bite. You blend it up. The pH goes above 4, often above 5, and it's anti-inflammatory, and you're good to go.
Brilliant. So we've got some few questions coming in here, and can I encourage people to type in questions in the chat box, please? Right. So, well, nice comment as well. Excellent presentation for SLPs in New Mexico. And then thanks a lot. So have you encountered any symptom complex that goes alongside this dysautonomia in long haulers?
Well, yeah, so dysautonomia, possibly coined by a PhD researcher of renown at Mount Sinai, New York City, named David Petrino, who's originally from Australia. The dysautonomia takes many different pathways. And if you really want to broadly look at it, when you have a vagal injury, you're going to have this dysautonomia, right? You're going to have shortness of breath. You're going to have cough. Some of the fatigue symptoms and so on, a little harder to tie into vagus. But remember, as ENTs, several years ago, Perry Santos at University of Oklahoma did incredible work on electrical stimulation of the vagus to treat depression that was intractable, refractory to medical treatment. So there's a huge psychotropic component to vagal injury. And the dysautonomia probably will bleed into some of the brain fog or emotional stress reactions that we see from these types of injuries. We don't know enough yet.
That's brilliant. There is another interesting question here. He says, what about the medical treatment for this condition?
Using medication, right?
Yes.
I guess that's the question. So as I discussed, medications like Neurontin, Lyrica, Neurontin is gabapentin, that's the generic name. People do use these drugs to treat people with vagal injury all the time. The problem is, to get a therapeutic response, you really typically have to get to well above 2,000 milligrams. I mean, we have patients on above 4,000 milligrams. And the higher you go with these neurotropic agents, they have a huge sedating side effect. And that's why we're so intent on pushing the physical therapy and dietary aspects of this. And our success rate is extremely high. And we have a whole series of exercises. Andy Schneider, Christy Block are some of the speech therapists that I work with here in New York. And there's a general set of exercises, and then we move it up another level, sometimes a third session, sometimes even a fourth session. We don't want to occupy everyone's waking hours with exercises, of course, but there are increasing level of exercises one can do to redirect the vocal fold closure. I mean, if you think about it, if you close your lips and sniff, right? Close your lips, sniff, you're going to stimulate from the brainstem, the posterior cricoarytenoid muscle. You'll open up the airway. So these breathing techniques take advantage of some of what we know about anatomical pathways. That's the best that I can explain it. And the medical treatment can be done, but there are tremendous side effects. And you have to think about this globally. If you can treat something with physical therapy and diet modification, that's a great place to start. The morbidity is very, very low. The success rate is very, very high. And there's a huge opportunity for patients to be creative in their own treatment, not necessarily with the respiratory retraining, but with the dietary side.
Right. That's brilliant. We still have some more questions coming, and I think we are still in time. It's brilliant that you've allowed time for questions in this very interesting area. There's another a comment, really, or a statement from someone. He says, in India, we advise vitamin C on long-term basis with lemons and oranges. What are your thought on this?
Well, I like the vitamin C. Lemons, I'm not excited about. And oranges, I would neutralize. And that's because of the, it depends, are we using vitamin C to boost the immune system? Okay, then why don't we add some zinc, and why don't we add some echinacea if we can? If it's, so again, large doses of vitamin C, that's an immune stimulant. I'm very into that. But what I would do to the citrus, you can keep the vitamin C, but I would neutralize. And I'll give you an example. It's called an orange cream smoothie. You take an orange, a banana, a cup of non-dairy milk. Again, oat, soy, coconut, almond, rice, cashew, macadamia, any non-dairy milk. And I'll tell you why we shy away from cow's milk in a second. But the 1 cup of non-dairy milk will neutralize the acidity of the orange, keep its vitamin C, but now you have an anti-inflammatory smoothie. So this concept of neutralizing acidic foods is something to think about. Let's see if I can get. Let me see if I can get back to this slide. Yeah, if you go to, hang on, I'm enlarging it. Yeah, if you go to acidwatcher.com, anyone can do this. Or if you have Instagram, you go to @Dr. Aviv, you're going to instantly see hundreds of recipes that use these concepts. So, thank you for that great question about lemon and orange, but neutralize. And the reason we're not fans of cow's milk contains casein, which is a very inflammatory protein. That's why we move more towards, especially after age 2, to the non-dairy milks, if you can. You may not have access, and that's a different story, of course.
Brilliant. There's another question again. Well, it's from Rohan. Thank you for the fascinating talk, which I totally agree as well. So in addition to the dysautonomia, have you encountered anatomical changes secondary to COVID within the larynx? And if so, how do you treat that?
So I've not seen, for instance, paresis, in patients who had uncomplicated COVID. So look, there's a slew in the ENT literature on laryngeal stenosis, severe granulomas, tracheal stenosis, subglottic stenosis, people intubated post-COVID. That's a entirely different realm. And I'm sure where you are at Guy's and St. Thomas Hospital, you're seeing these patients. For the outpatients who have not had organ damage, I consider that organ damage, right? So for those that haven't had organ damage, and that's more along the definitions of long COVID, is no organ damage, but symptoms, we are seeing plenty of this paradoxical motion. And this is why we're here.
Just to add into that, my experience is similar to yours as well. The patients that will have structural problems are the ones that want to have intubation. That's mechanical ventilation and tracheostomy, and really is mechanical trauma. That's the cause of the injury mainly, as opposed to the COVID itself. So the next question is, what about multivitamin role for this?
Again, great question. I love multivitamins. The one thing, at least in the United States, that we have to be very careful with is that the supplement industry in the United States is one of the most poorly controlled parts of healthcare. So I have no issue with supplements, but the caveat is please run it by your physician or your healthcare professional, so that we know that what you're taking is what you expect. That's the one thing you have to urge a little caution. One of the reasons I like these food-based solutions is pretty much when you're using some watermelon, using some cucumber, and by the way, the best cucumbers, of course, the English seedless cucumbers. It's a whole food. I guess you sort of know what you're getting. As you start to get into supplements, it gets very, very tricky. So not against it, but just know what you're putting in your body.
Okay, there's another question here. So can you please give brief about the supplemental nutritional requirements in COVID?
So again, there are two ways to look at it. One is boost the immune system, right? So that you can fight COVID if you get it. And there's some literature on that. This is frankly what drove me to start every day, and I've continued with one of these smoothies. And I did point out that herbacetine, think of herbs, herbacetine, Herbacetin, which is big in flax meal, has the ability to bind to the CL3 protease in the cell, so it can help prevent some of the cell damage from COVID. As it turns out, early on in our experience in March, April, May, Columbia University published a study on using famotidine, which we call Pepsid here in the United States. It's an H2 blocker, right, an acid reducer, because they felt that it would help improve or prevent COVID from having its full nasty effect. But it's the same reason. As it turns out, famotidine binds to the CL3 protease in the cell. So you have a pharmaceutical option, but you also have a food option.
That's brilliant. There are some few more questions here. If it's all right, we press on with the questions.
Please.
Well, this just a comment. Oh, no, before that is any alternatives to watermelon and cucumber? Also, is smoothie better form, or can eating them raw would be equally effective? I think
Yeah, yeah. So
maybe just
people
taking a bite
always,
on it.
yeah, people always ask, can I just eat it? Yeah, of course you can just eat it, but there's a reason I want to combine two anti-inflammatory agents, lycopenes and lignin. And when you drink something, it's going to spread over a larger surface area than when you're eating something. So it's a mechanical thing. But as always with these things, we give the ideal, which is, blend it. Some people don't have a blender. You don't have a blender? Of course, eat it. Take a bite, take a bite. It gets a little tricky if you have something acidic and you need to neutralize it. Take a bite won't work, right? See, I guess you can mash it up. But we have found that, blending is the most efficient way to get everything accomplished. And as you can't do what you ideally want to do, you can take other steps. Look, at least in the United States, none of us eat enough fruit and vegetables. So anything in that direction, I applaud. I don't care how you eat it.
Do you peel the cucumber, or do you leave the skin on the cucumber?
No, I don't. I leave the skin on. Just chop it up, throw it in.
But the watermelon, you take the skin off.
Yes, I should say that. Yes, absolutely. Don't eat the watermelon skin.
Right. Just a comment, rebreathing again from someone else's question here. Rebreathing, retraining, physiotherapists are very well equipped to do this. Certainly in the UK, I would say physio instead of SLT. Right. It's a comment.
So, yeah, I mean, look, physical therapists can do this. Physiatrists, rehab medicine professionals can do this. The problem is, because up until this time, it was quote unquote relatively rare to see paradoxical motion of the vocal folds, usually as a consequence of a viral injury, and it's what we call neurogenic cough, right? So here in the time of COVID, where the numbers are astronomical, that's why I went through that, the numbers are in the millions. I think the demand for people who have this skill set is going to be extraordinary, and extraordinary for years to come. This is not going away September 9th.
I think here in my hospital, in Gaza St. Thomas Hospital, the speech therapists are very well involved with anything to do with the vocal cord paradoxical movement. So it did, along with the respiratory physicians and the physiotherapy, as a multidisciplinary team, because everyone has got.
I mean, that's great. I mean, your team is ideally set up to do this, and do you already have a post-COVID clinic in your hospital?
Yeah. So the next question is, what are some of the training exercises? Does this definitely help improve the basal paradoxical movement in the long term once exercise have stopped?
So that's a great question. So what we have found, and we see these patients back, right? So they come in, we make a diagnosis, and generally I bring them back 6 to 8 weeks after the initial visit to take a look. Sometimes a lot of, I would have to say almost 80% say, I feel great. We look anyway, just to see. Some people say, I don't feel that great. And we look, you can actually tell now, we see 3 green trees, the larynx opens instead of closes. So you can actually, and showing that progress to the patient is just invaluable, because it gives almost a feedback. So patients understand what they're doing is working. So they get better, and then they go on holiday, they're on a plane, and they get sick again, right? They get a cold, and they start getting the feeling coming back, the tightness, the chest tightness, the shortness of breath. So I say to patients, now you know what to do. You immediately launch into your exercises, right? So knowing what to do as it might come back. And often it does. If you think about the whole concept of neurogenic cough, you have a cold, your vagus is injured, it's susceptible to injury again. But now, instead of running around to physicians for could be years, immediately you launch into the exercises, you get to your ENT, and we take a look.
The next question is that you mentioned about the acid watcher diet. Could you tell us a bit more about it? And could we have the recipe for the Bargava Martini, please?
Okay. Yeah. So the acid watcher diet was developed several years ago. It's a low acid, high fiber, nutritionally balanced diet. It's not a deprivation diet. So what we're trying to do, the essence is to stay away from foods less than pH 4. This sort of evolves a little into reflux disease. Everyone's obsessed with acidic foods coming up, acidic contents hurtling up to the larynx. What I believe happens in many more cases than that is what I call, instead of reflux, acid influx. So just very briefly, there's an enzyme in the stomach called pepsin. Pepsin breaks down protein in an acidic environment. The stomach's very acidic, it's pH 2. Pepsin gets activated below pH 4, but pepsin can float. In fact, it was Nikki Johnston, who is a researcher in Birmingham, UK, that described this about 10, 11 years ago. She's now working at University of Wisconsin in Madison, the United States. But she was one of the first to show that pepsin can sit in the larynx, the mouth, the sinuses, the middle ear spaces. And when you eat or drink something less than pH 4, what you eat starts eating you. So that gave us the basis of this diet, where in what we call a healing phase, you want to eat foods above pH 5, and that's just a handful of weeks, it's 28 days. And then moving forward above pH 4, which we call a maintenance phase. So we've developed recipes and all sorts of ways to use food-based approaches to treat both acid reflux, acid influx, and the symptoms that it causes. We just came out with a cookbook called the Acid Watcher Cookbook, and I want to thank my co-author, Samara Aviv, who really pushed the food envelope. So now people with reflux disease can have tomato sauce, tomato soup, pizza, desserts, decadent desserts. But the essential is it's above pH 4, above pH 5. The most recent rendition, there are over 100 recipes, and if I can make them, anyone can make them.
Brilliant. A couple of questions here. Any role for Botox or melatonin?
So let's talk about Botox. We hear a lot of Botox for paradoxical motion. Again, I'm not a fan, right? One of the things even more common than Botox is the use of anesthetic to the superior laryngeal nerve. That really worries me. You knock out the airway protective reflexes, which is what numbing medicine in the neck, xylocaine to the superior laryngeal nerve is going to do. You run risk of aspiration. People say, well, these are people with intractable cough and nothing worked and so on. Well, on a case-by-case basis, we can assess that. But in general, I don't see the role for Botox with this. This is not a spasm. It's a neural pathway that can be redirected with physical therapy. And as head and neck surgeons, when you're a hammer, the whole world's a nail. You just want to get in there and do something. The concept of letting the speech language pathologists share their expertise and treat, and some dietary modifications to calm the whole area down, is not what we're taught in training, right? Yakuba, they didn't teach you that in training. Dr. Garber, they didn't teach us that in training. We sort of developed these concepts along the way. Now, getting back to the martini. So if you take this watermelon cucumber puree, right, a cup and a half of watermelon, cup of cucumber, a handful of ice, 2 fingers of a corn-based or a potato-based vodka. You've got I can't say an anti-inflammatory beverage, but put it this way, it won't be an acidic beverage.